Hello, I'm William Zoghbi, Chief of Cardiology here at Houston Methodist and the DeBakey Heart and Vascular Center. And it's a pleasure to have today Dr. Chris KRAMER from the University of Virginia. He's Professor of Cardiology and Radiology and the Head of Cardiovascular Imaging at the University of Virginia. Chris, great to have you.
Bill, thanks for having me. It's great to be here.
We really enjoyed your grand rounds today, and I would like to point our viewers to check his grand rounds, which is really amazing, about hypertrophic cardiomyopathy, and discussed pretty much everything about hypertrophic cardiomyopathy, in addition to this wonderful registry that you're co-PI on, multinational registry on hypertrophic cardiomyopathy, and the use of not only imaging, MRI with gadolinium and everything else, but also biomarkers and genetics. And I think it's going to be phenomenal, Chris, really. The question to you is, I know we're awaiting, the ultimate results and everything else. How representative is this registry of hypertrophic cardiomyopathy patients that will be seen in cardiologists or internists? Are we more selective, do you think, or?
Well, I think the patient population, we recruited 2,769 patients total, is representative of patients with HCM who would be presenting to your office for initial visit and evaluation for HCM. Those we excluded are those who already have interventional therapies, either myectomy or alcohol septal ablation or ICDs. So you should think of our population as a de novo first-time evaluation for HCM. And then they got enrolled in our registry. We took baseline history, got all their clinical information, their prior echo information, and then performed a cardiac MRI and drew blood for both biomarkers and genetics. Now, after their entry visit, they might get an ICD. They might get, and a certain percentage did, about 10%. They might get myectomy or alcohol septal ablation, about 5% did. So you should think of it as the first time a patient with HCM comes to a cardiologist's office for evaluation. Those are the type of patients that got enrolled in our study.
Beautiful. I think it will really shape management, and we can't wait to see the results of this, particularly using MRI with T1 mapping, looking at interstitial fibrosis in addition to replacement fibrosis, and I think that's going to be phenomenal. Share with the viewers for patients who are symptomatic, how do you choose, and they failed medical therapy, if you will, with an obstruction, how do you choose in your institution between, let's say, myectomy, surgical versus alcohol ablation? Is there some criteria that you would use? Our center has been doing both,
right.
And we started with septal, alcohol, septal ablation many years ago, and we have experience with a lot. I just wonder, in your view, of how do you choose at the University of Virginia?
That's a terrific question. As you know, there aren't randomized trials, unfortunately, in this area, and it would take, unfortunately, thousands of patients that has been examined to really answer the question once and for all. We approach our patients based on U.S. guidelines, which suggest that a myectomy should be the therapy at least considered first, and it will look at the patient, decide if they're a good myectomy candidate. If they are, we generally think of that procedure first as a definitive procedure. The outcomes in the right hands are terrific, and they are at our institution. The alcohol septal ablation is certainly an excellent alternative with long-term outcomes quite favorable. We generally reserve alcohol septal ablation for patients who are perhaps higher risk for myectomy, elderly, frail, contraindications for one reason or another for surgery. And those are the patients that end up with more commonly with alcohol septal ablation, and they're referred directly to our interventionalists because they're thought to be not terrific candidates for myectomy for whatever reason.
And so that's condition for the heart failure, for the heart team, if you will, approach the surgeons, the interventional cardiologist, and the clinician to take a look at that, make decisions. I think that's wonderful.
And before myectomy, we sit down with our surgeon and review all of the imaging data, the echo, the cardiac MR, and so that the surgeon can develop a picture in his or her own mind about what the procedure that he or she is planning on doing needs to entail, because it's so important going into the surgery that they have a clear-cut plan of the area of the septum that they want to treat. Now, it turns out when you look at imaging studies of myectomy versus alcohol septal ablation, there are different parts of the septum that are treated with those two procedures. It's remarkable that both work as well as they do. So they really treat different parts of the septum.
A little further distal with the alcohol ablation, where the septal perforator is, as opposed to shaving off, down the barrel from the aorta, to the septum. I think it is amazing. It's a great option actually for patients to be able to have both.
Yes.
Well, Chris, it's great to have you, and good luck on the registry. I think it's going to be very powerful, and we look forward to having the final results in a couple of years.
We look forward to getting them to you. Thanks for having me.
And thank you again for joining us, and we look forward to seeing you in another Grand Rounds. Thanks very much.